So next I have the privilege of introducing my very old childhood friend, Dr. Ansaar Tariq Rai. He's the one to whom I went first in USA to understand what this stroke intervention is all about. And I am very grateful to him for giving me so much of time with so much of patience and the kind of attention that he gave to me and the time he spent with me in taking me through all the steps of stroke intervention. So Dr. Ansaar Tariq Rai is Professor and Vice Chairman, Director, Neuroendovascular Fellowship and Research, Department of Neurosurgery. He's Vice Chairman of Radiology, Professor of Radiology, Neurology and Neurosurgery, West Virginia University Hospital, Morgantown, USA. And over to you, Ansaar.
Thank you very much, Asim. It's certainly an honor to be here. I appreciate and applaud the initiative that Asim has taken. I will start off by showing some baby slides of Asim and then go from there. Okay, thank you very much. Can they see? Is the presentation on there? Okay.
Yeah, presentation is on.
So, I'm going to talk about stroke imaging, but briefly I will take 2 minutes because of some of the discussions we've had over the last 2 years, why RIC and why this initiative is so important. This is where I practice. It's in West Virginia, 900 bed hospital. It serves this population and this community. We did a population study based on our catchment area and extrapolated it to the US population to determine what is actually the burden of this disease. And we assessed that it is about 31 new large vessel strokes per 100,000 people per year, range of 26 to 35. And this translates to about 100,000 new large vessel strokes every year in the USA. The STEMI rate, reported rate in the US is about 70 to 80 per 100,000 per people. So the LBO stroke rate is about 1/3 of the STEMI rate. And if you translate that to the population, Rawalpindi Islamabad population is about 3 million, but obviously your catchment area is different, and I will show that. So in 3 million people, you should see 3,000 STEMIs, but RIC alone does 5,000 to 6,000 primary PCIs per year, which means that either the disease incidence is much higher in our population due to high prevalence diabetes, hypertension, other risk factors, or that your catchment area actually extends beyond what the Twin City metropolitan population is. But the LBO, because the STEMI, what Dr. Sabri says, it's like STEMI, but it's also not like STEMI. The margin of window for operation is a little bit less. So even if you take the 3 million Twin City catchment population and use the rough incidence of 30 to 35 per 100,000, you're looking at least 1,000 new large vessel strokes every year. Even if you treat 25% of that, you're looking at 250 thrombectomies per year. And if you extend your catchment area to what the STEMI is by developing systems of care, emergency medical services, you're looking at almost 2,000 thrombectomies every year in this, serving this center can serve a large population. So what does it mean? If I'm the government of Punjab and I show them this presentation in Naya, Pakistan, the first question is, what do you need for this? So you need logistics, you need equipment, cath labs, devices, imaging, building, ER, pre, post, personnel, physician, techs. And if I'm a state funding authority, I will look at what is already available. It makes no sense to make an institute with duplicated resources, cath labs, techs, when you are going to do 1/3 of the procedures that are being done for STEMI. So it makes logical sense to use existing infrastructure that can deliver this care 24/7 and use the same resources and not duplicate them. With that, I'll move on to the imaging component. Imaging is important for patient selection. Appropriately selected patients have a better outcome. Intervening on infarcted brain can not only be futile, but can be dangerous. The imaging criteria are not absolute. Obviously, we are clinicians and we take into account other patient factors, age, comorbidities, premorbid status. Imaging is a tool to guide and tailor therapy. For patient selection, it can help in triaging the patient. Outcomes depend on proper triage. The goal of triage is to identify cell death, and the markers of cell death are cytotoxic edema, which is infarcted brain, and on the vascular side, it's microcirculatory failure. Time is used as a surrogate for cell death. So the 3-hour, 6-hour window is not absolute. It is based from NNDS trials from 1995, because at that time these imaging tools were not available, and it was used to capture the largest amount of patients that we can. Imaging is a more reliable indicator of permanent cell death. The ideal first-line imaging study for stroke has to be, of course, fast. It has to be available 24/7. It has to be accurate, economical, safe, most important, and it has to be simple so that it can be reproduced in multiple centers without complicity. We have non-contrast CT, CT angiography, perfusion, and MRI. I think, in my opinion, and in centers such as in our center, we don't use MRI because the logistical issues with MRI are harder. CT, there's 5 CAT scanners available for every 1 MRI, at least in the US. And so CT is more available, more economical. Non-contrast CT is at the least required imaging modality for acute ischemic stroke. And there is a lot of information on non-contrast head CT. I will not go into the details of aspect scoring, but basically it divides the brain into vascular zones. This is for the middle cerebral artery, frontal, parietal, deep gray nuclei, lower level, and then along the vertex. These are listed here. The total score is 10. A low score means bad aspects or infarcted brain. I will show some examples of that. And this is a CT scan of the brain, normal patient. Perfusion imaging I will go quickly over because I think it can add value, but I don't think it's critical in triage of stroke patients. It assessed the microcirculation. Ischemic penumbra represents salvageable brain. So the ischemic core, the cerebral blood flow, is 10 to 15 ml per 100 gram per minute. At that level, there is irreversible cell death. But there's an ischemic zone where the blood flow is between 15 to 35 ml per 100 gram of brain per minute, which is a symptomatic brain where there is neuronal conductive failure but no cell death. Assessing microcirculation, we measure brain perfusions using a tracer, which is the contrast, arterial site, venous site, tissue concentration. I will not go into the detail of the kinetic theory, but basically cerebral blood flow is measured per minute. Cerebral blood volume is the total blood volume in that part of the brain. If you take a sponge and squeeze it, what comes out of that is the volume. In cases of obstruction, the cerebral blood flow is reduced, and we already talked enough about collaterals, and collaterals take over, and the perfusion imaging indirectly assesses the blood flow based on these collaterals. This is done to maximize oxygen extraction. So you have cerebral blood volume, which is ml per 100 gram of tissue, cerebral blood flow, which is 100 gram of tissue per minute. Transit time is the time it takes for the blood to enter the brain and come back from the venous site, typically 3 to 4 seconds. And this all correlates with outcomes, and this is a mismatch between blood flow and blood volume. This also correlates with collaterals. This is grade 0, no collaterals. Grade 1, somewhat back to the occluded site. And grade 2, you can see it's back almost all the way distally to the site of occlusion. As cardiologists, I think you're fairly familiar with the role of collaterals in sustaining an ischemic tissue. And in our own data and publication, this correlates with cell death and irreversible brain damage. The higher the cerebral blood volume core infarct, the more likelihood of permanent cell death. All these criteria correlate with outcomes. They correlate with mortality. I will go on to case illustrations. Briefly, 68-year-old woman, right hemiplegia aphasia, and a stroke scale of 17. So this is the first study we do, which is a non-contrast head CT, and I will briefly scroll through it. And at first glance, this does not look that bad. There's the first area we look at is the basal ganglia, which is the deep gray nuclei. They are still preserved. If there is loss of deep gray nuclei, it implies an M1 occlusion because it covers and blocks the lenticular striate arteries, which are end arteries. The second component we do along with that is a CT angiogram, and this gives us a roadmap from the aortic arch to the cranial vertex. This is very useful in assessing the access to the lesion. So there's the middle cerebral artery on the right side. On the left side, there is an occlusion of the left middle cerebral artery, but we can also see the entire carotid artery up to the aortic arch. This is extremely useful in planning choice of devices, what we're going to use to access the intracranial circulation. The third component is CT perfusion, and this shows the perfusion map on the corresponding left side, which shows that there is an increase in the transit time over here, decrease in the cerebral blood flow, and fairly preserved cerebral blood volume except along the deep gray leukemia, so fairly large mismatch indicating cell-variable brain. But again, this is not a requirement for intervention. All you need is non-contrast CT. This patient goes to the cath lab. There is the left M1 occlusion. There is partially occlusive thrombus. There is occlusion distally within the inferior division. This is the lateral component of the same, showing the occlusion. This is post recanalization. I'm not going to show the procedure in this talk. And this is the follow-up MRI, which shows that the stroke was limited to the area of core infarct on the cerebral blood volume. 75-year-old gentleman, left hemiplegia, and a stroke scale of 9. And again, we start with the non-contrast head CT. Again, good aspects. Obviously, these are patients we intervened on, so they had good imaging criteria to start with, indicating good thrombectomy case. There's an old infarct. CT perfusion, I will skip here, show the CT angiogram. And this is important. The arch, as Attila mentioned, here is fairly straightforward arch. The carotid artery, there we can see calcifications, but otherwise fairly straightforward carotid artery. Pre-angiogram, this is the guide catheter, occluded middle cerebral artery with good collaterals. That is why the perfusion is preserved. This is pre-post recanalization of the bifurcation. And the follow-up MRI showing again a small infarct compared to the area at risk. 82-year-old gentleman, this is a case from at least 15 years ago. NH stroke scale of 20, presents 7 hours after waking up with left hemiparesis, low NH stroke scale. Has an ICA terminus occlusion. This is the Mercy device. And then this is the final infarct. So imaging can help identify patients even late onset, which what the Dawn trials show. This is a 26-year-old gentleman, again, this from 10 years ago, woke up with a deficit of 22. Now, this patient would have been excluded from any treatment at that time. Perfusion shows large abnormality on the right side, occluded ICA terminus that is recanalized. And this is the final infarct, which matches what we see on the core cerebral blood volume. So even if we did not have CT perfusion based on the non-contrast CT, we would have intervened. It's an 83-year-old, fairly good aspects on the non-contrast CT. Just the imaging shows that the entire right hemisphere is at risk, secondary to an ICA terminus occlusion. This patient was not treated, was given IV TPA, and has a massive infarct and died. This is an 86-year-old with completed infarct on the cerebral blood volume. Also in this patient on aspects, there is already loss of gray-white, big ICA terminus clot, and these patients received IV TPA, large infarct and hemorrhage. This is a inferior division parietal or angular branch, which shows deficit in the parietal lobe. This patient just received IEA TPA, and there is recanalization and preservation, except the small area of infarct, which was previously dead. Now, this is an example of dead brain. 53-year-old male, not waking up after parotid surgery. The entire right cerebral hemisphere, cerebral blood volume has a large core. Not a good candidate for treatment, but it's a young patient in-house early on, has a tandem occlusion of the carotid artery, heavy calcification. We did intervene, opened up most of it, but the patient suffers a large infarct, hemorrhagic conversion, and passes away. So the pre-op imaging is important. In conclusion, imaging can help in patient selection, should not delay care, however, so it has to be streamlined, the process has to be efficient. That is why it is important that it is done in institutions where we have already capability, as I mentioned earlier, based on the infrastructure, to do this not just a few hours a day, but to deliver this 24/7. Non-contrast CT is essential. CTA is desired. CTP is only if the imaging processes are streamlined. It is not critical to the triage of acute stroke patient. Thank you very much.
Thank you very much, Ansaar. We still have 5 more minutes. Thank you very much to all my participants for sticking to time. So we have 5 more minutes for question answers. We've got 2 mics in the middle of the hall. So anybody is welcome to walk up to the mic and ask any questions if you like. Dr. Ansaar, so what's your imaging strategy for posterior circulation stroke?
Good question. So posterior circulation stroke, basilar strokes, the mortality for an acutely occluded basilar approaches 98-100%. And we use imaging to screen if there is already infarcted brainstem because the patient may be comatose, the exam may already be pretty severe. And in those cases, we may use an MRI to determine if there is viability within the brainstem, because if there is no viability, there is really no benefit of intervening at that point. We may be just prolonging, it is hard to say that, but we may just be prolonging the patient and the family misery by partially recanalizing an occluded basilar in an infarcted brainstem. And so in that scenario, we may use MRI to determine, but if the patient is presenting early on, the non-contrast CT does not show a brainstem infarct, the basilar is occluded, we will give the benefit of doubt to the patient in most cases and take the patient to the operating room.
So does CT perfusion have any role in this?
Not really. We looked at our own data, other centers have looked at it. I don't think there is any role of CT perfusion in posterior circulation.
Great. So any more questions from the audience? Or from the panelists, if somebody wants to discuss anything?
We do some carotid arteries, and the biggest challenge is the negotiation of the, like you said, the hostile arm. So how difficulty, like we can use the same for cannulating, and how challenging is this in acute setting if patient unwell?
Yes, so access is critical and we have some live cases I think we can discuss. The access is critical in determining procedure time and success of recanalization. If someone is spending half an hour on access, by that time, the relevance of recanalization may not be that much. So there are tricks to access a hostile aortic arch. There's exchange length maneuvers, there are different guide catheters, there are alternative accesses such as the radial or brachial artery or even direct carotid puncture. That's where the preoperative CT angiography is very useful in showing whether the arch, I've had a case where the arch was fairly straightforward, but had heavy thrombus, calcium. You could see the thrombus hanging along the arch curvature, and we avoided the arch when through the arm. So there's alternative access, there are alternative catheters, devices, long sheets, stiffer sheets, triaxial, coaxial systems, and typically the stroke intervention procedure should not last more than 20 minutes to 30 minutes. If it goes up to an hour, the outcomes diminish remarkably. If after 3 or 4 attempts there is no recanalization, the success of a good outcome is very, very low. So we have to make those decisions early.
So if you come across a carotid artery stenosis while you take the scout pictures, would you fix the carotid first, then go up?
Yes, there is a whole talk this afternoon on tandem carotid strokes. We will discuss that.
Great. Thank you very much.